Good morning, everyone, and welcome back. This is Catherine Piers, and I'm joined by our hub team members here, as well as our presenter for today. While everybody is hopping on, I'm just going to go over a few little housekeeping notes. Many of you are probably familiar with these, but in case we have anyone new, I am just going to quickly go through them. These are our hub team members. Kathy Bishop will be joining us. She may be a little bit late, but she will be with us shortly. And I don't think Fawnette is on, but hopefully she will be with us shortly as well. And this is being recorded, and the link to the recording will be sent out after the presentations and session ends today, probably by later this afternoon. If you have any questions, you can put them in the chat box. If you have questions for our presenter, please feel free to put those in the Q&A box, and we will be monitoring those as we go along. So don't feel you have to wait to put your questions in until we get to the end or we announce a formal Q&A period. Just feel free to put those questions in as they pop into your mind. You're all muted by default, but if you do have a question that we want to hear from you directly, we'll ask you to unmute before you start to talk. And we will get started in just a minute here. And you can also, if you have something that's important, raise your hand, use the little hand function. And so with that, I'm going to stop sharing my screen and our speaker can start doing hers. And Cameron, I'm going to turn it over to you, our fearless leader.
Good morning, everyone. Welcome to our July installment of Project Echo. Those of you who have been with us faithfully month over month are very familiar with this format. For those of you who are new, I just want to mention that Project Echo is an initiative of the University of New Mexico years ago who aimed to move knowledge to rural areas rather than moving people to rural areas to teach those there about whatever medical topic the Project Echo wanted to educate. So we're glad that those of you across the great state of Texas are here to learn. And another slogan of Project Echo is that all teach, all learn. So even though we have a guest to begin our session together over the first 20 to 30 minutes, we hope that as our conversation unfolds, both about that didactic topic and then eventually about a case to follow, that you'll feel welcome to either unmute and ask questions, add your own comments, or likewise, we welcome you to do that in the chat box. As your facilitator, I'll be the one to find the right time to interject and let Chrissy, our guest speaker, know that you are interested in more information on a given point that she's covered. And I'll let you know, because she is our guest, this issuance in the month of July, we're giving her a full hour to cover the breadth and depth of the information that she wants to bring to us. So you may know, because you received the flyer in advance of today's session, that Dr. Marsak Topolewski is joining us, and she'll be teaching us about advanced care planning for individuals with lifelong disabilities. So Chrissy, welcome. We encourage you to let us know a bit more about your expertise, where you're joining us from, anything else you'd like to share, and then the webinar floor is yours.
Thank you. And welcome, everyone. Thanks so much, Dr. Jeter. I'm Chrissy Marsak-Topolewski. I'm an associate professor of social work. I'm at Eastern Michigan University. I live in Metro Detroit, if any of you have been there. And my background, first and foremost, is in special education. So I spent a part of my career working in a public school setting with students with different disabilities, predominantly adolescents. And kind of along that time, I got my MSW, my master's in social work from the University of Michigan. And then I was very, very interested in aging, though. And they always said, Chrissy, you'll never be able to do both. And so I was a geriatric fellow at the University of Michigan, but I also did the school social work path. And they always said, you'll never do both, kind of thing. So my background is in special education and gerontology, and I've been able to kind of bring those two worlds together as we start to think about some of these lifelong intricacies and what this looks like for populations. Certainly with ID, but also their family caregivers. I often in my work talk about kind of this back and forth nature. If we can support family caregivers, we oftentimes can better support our consumers, clients, and patients, and vice versa. And so I've used that kind of to go through. And so that kind of led me to my doctorate in social work, and I have a dual title in gerontology for that. Most of the work I do as an associate professor of social work is really in kind of the research world of things. I am an appointed member for the National Task Group. For intellectual disabilities and dementia practices. I'm a big fan of everyone involved with that. And most of my work and publications really centers on individuals with intellectual disabilities, autism, and other neurodevelopmental disabilities, and family caregiving and aging. And so I'm going to talk about this topic, which is, I think, really, really a huge, there's a lot of importance as we start to think about what this looks like, not only for individuals with ID, their families, but also even for those of you who might be working in medical centers, health facilities, might have loved ones of your own, as we start to think about how do we start to unveil some of the ways forward to really kind of codify good plans to support people along the way. So there are talks about kind of end of life, advanced care planning, and these aspects. And one of the things it really does is it really kind of unveils and it really makes things easier, hopefully for everyone involved when we have some pre-communicated things. I'm just looking here. I do have my email address here as well as some other information just about me in terms of my bio. So, in the chat is open. So, if you have anything that comes to mind, feel free to put that in the chat. But as you even think over the last year, or even some of you may even think back to like kind of when COVID set in, how would you describe in words what that last year has looked like for the individuals maybe you serve or you might come into contact with who do have IDD and for their caregivers? So, that chat's open. Feel free to just pop anything in there. And while you're thinking and kind of reflecting on that, I'm just going to share a couple things as I do this presentation for different audiences. Oftentimes people talk about just the social isolation, the fragmentation of services, how a lot of our family caregivers, and there's a lot of them, right? There's likely what we think 53 million, and I say plus, family caregivers across the US, and many of them who are not family caregivers really anticipating to be a family caregiver in these upcoming years. But people talk about, navigating services in the unknown. And when it comes to advanced care planning, really not always having the time, the capacity, the bandwidth, or really kind of a nice trajectory to really engage in that. Oftentimes people talk about really, really, really just being centered in kind of the day-to-day realities and the needs. And some of us even think about our own lives and our own families, right? The work we're doing or the family caregiving things that we might be balancing and so forth. We might think about these aspects, and just for some of our clients, consumers, and patients, these may be augmented in terms of that really difficult juggle. Catherine Pears put something great in the chat. She indicated that, many people have reported that since COVID, they have seen an increase in behaviors in their family members or the people they work with. Yeah, absolutely. So the behaviors, and we're seeing this, I still do work with directly with this population, but we're seeing different kind of profiles or perhaps exacerbation of behaviors. But then when we even look at our provider professional bandwidth or services, if somebody's accessing other things like respite care, that network's not in place to the extent that it should be. So yeah, great points regarding behaviors and what that might look like. If you are a family caregiver or you're supporting family caregivers as a professional, we think about a lot of our families or our direct service providers, they're taxed, they're exhausted just from kind of navigating these elements. So when we think about and bring it back to this topic of advanced care planning, how do we even go forward in this journey of planning when we're just kind of attending to these day to days? So I just again want to welcome you and thank you for being here. Feel free to put any information about yourself in the chat if perhaps if you don't know people, it's sometimes nice just to get a pulse and a sense of who's in the room. But I'm going to start off with kind of an overview just to kind of center us and where we're going. When we think about populations with in intellectual and developmental disabilities, or IDD, um, this population often is forgotten when it comes to conversation, planning, and services in adulthood. I once heard somebody really incredible speak and said she really kind of got to the crux of it of we're oftentimes talking about developmental disability and aging in these two different worlds. And so as we bring these together, because I think it's really important as we start to really grapple with the many people with IDD who are aging, some with some pretty specific precursor conditions, and then along the way experiencing some of these more normative aging realities. I think it's really important to kind of bring these worlds together. Certainly COVID was a huge wake-up call for I think a lot of us. I sit kind of in that mental health space when it comes to disability. And as we look at even what's happening with the general population with developmental disability, or I'm sorry, the general population here across the United States, mental health has really taken more of a front stage in terms of even an awareness. And so as we think about what COVID has done and some of these things and the wake up call it's been, and certainly what this has done for the broader caregiving network as we start to move forward. And how do we even look at where those gaps are in planning um, when, for health changes and for like kind of those final days. And so we're going to talk about a framework to better understand kind of this multifaceted nature of advanced care planning. Throughout this, I'll be at times using acronyms. So you may hear the acronym advanced care planning. You might hear ACP as that acronym for advanced care planning. We'll talk about barriers to advanced care planning and some of the reasons. Why is this important? Why can this be so efficacious? And what do we really want to kind of think about in that regard? And we know that the number of older adults are increasing, and people in terms of longevity, that is changing for the IDD population as a whole. And so I'll talk about some of those things and what that looks like. And then in some, we want to really look at like what practical information might we be able to take back to whatever setting we're working in, whether that be research or medicine or healthcare in some other capacity. All right, so here are the objectives for today. And certainly some limitations and risks. I just want to note the various array of things that might come into place when somebody's aging. So as we think about normative and non-normative health changes, challenges, declines, whatever we want to think about, and certainly given the various symptoms, characteristics, conditions, and manifestations, and what this looks like across the lifespan, it's really important to kind of just for me to articulate. Certainly, advanced care planning is going to look different. It's going to vary, and the needs and the considerations are going to vary greatly. And so we certainly won't be able to cover every aspect of these topics. And there's different things even across different states that might come into play as we think about what programming, what services, what things to be aware of. Sometimes I do talk with a colleague she's an attorney with an LLM. We talk about things as it would pertain to even guardianship, and across state lines, things will change there as well. We know that supporting those who are aging with IDD is complex, it's multifaceted. Even when we think back to Catherine Piers's comment in the chat, just about the difference in behaviors and perhaps some escalation or new behaviors that somebody might be seeing, those complexities really can kind of filter in even from that perspective. So because of the variance and the complexities and the multifaceted nature from person to person, treatment, supports, and resources, there is no one size fits all approach. I do a lot of webinar trainings, and I often talk about this. It's like we wish there was this one size fits all approach, and there just isn't, especially when we're looking in the world of disability, or certainly with any human population. And so as we move forward with this, and as we think about perhaps the clients, consumers, patients, the people we might come into contact with, certainly a tailored approach and individualized approach is needed. And I'll always say, when possible, working in an interprofessional or interdisciplinary capacity, this can really be certainly efficacious as we start to think about how do we really move forward with comprehensive, well-rounded treatment and services. All right. So if anything comes to mind, feel free to put that in the chat. But when you think about advanced care planning, oftentimes people are thinking about all sorts of different things, right? They might be thinking about it perhaps from like the paperwork standpoint or the barrier standpoint, or these very specific nuances that really should be considered as we get into more of a granular level of looking at very specifics in someone's life. I always like to think about why we're doing this work, and just to kind of put myself there. I've worked with individuals with intellectual and developmental disabilities for about 20 years now, professionally, and I think about these different individuals that come, the different people that come to play. Um, we know that individuals with developmental disabilities should have a major role in planning for all facets of their life. And so when we're thinking about end of life care, and we're thinking about the meaning behind this, and we're thinking about what this means for somebody to really be included in the rituals as it pertains to death and dying, I think this is really, really important. We also know that healthcare providers, family caregivers, agency staff, for people with IDDs, they can experience all sorts of different things as it's coming into play. I want to share a story. I did some work in nursing facilities, and I went into nursing facilities and I was doing assessments for individuals who might be able and interested to transition out of those facilities, kind of receive some wraparound services so that they could be in their homes. And we know there's this big aging in place movement. People are wanting to be in their homes to the extent possible, whatever they might consider their home setting to be. And part of this work was actually looking at some of the complaints that had come forth from families, as kind of an aside that kind of sat simultaneously with this at times. And there was an individual who was passing away, and she was in kind of her final days, and the family wasn't able to get the right paperwork in place. She was dying of a condition at the time that people thought was very, very contagious. There was a lot of misconceptions around that. People were afraid to go into the room. People were afraid to touch her. People were afraid to, even breathe the same air. And hence, this certainly has an implication for programming. And the family was living outside of the state of Michigan, and they found an organization that would bring in a plane and bring her back to die with her family in her home state. And she would be surrounded by the family. Well, the paperwork wasn't done in a way that the facility could legally discharge this individual. And she ended up dying in this facility alone. And we think about this, and we think about these barriers to all sorts of things, whether it be a timely diagnosis or whether it be barriers to receiving hospice care, or palliative care in a way that would be really best for that individual. Or we think about in these like pretty extreme situations that somebody actually could have been brought back to spend kind of those final days with the family. Lots of things going on. I'm going to share a piece, and this is from an article I co-authored with a dear friend and colleague, Jackie McGinley. And Jackie is a professor out in New York. And there's just a quote that I want to talk about it when we think about just some of these barriers that people receive. Here's this quote. This was published in 2021. Barriers to timely diagnosis have implications for survival, while delayed discussion about prognosis may impact the quality of the dying experience. In this study, both individuals experienced relatively brief end-of-life trajectories, including short lengths of stay with hospice. And then it goes on to talk about, people dying with some of these different symptoms and illnesses, and differences in kind of those end-of-life days because of perhaps some barriers or limitations in their own advanced care planning. And so really these aspects and these needs for planning are so important. So I give kind of these two different examples of, somebody with a hospice and palliative care, but then this pretty extreme example that I saw in real life where somebody wasn't able to, because of the paperwork and because of the planning piece, wasn't able to be legally released from, a facility, and what this can look like. I have some information about legal guardianship. We know that sometimes individuals that we might be working with may have a legal guardian. They may have some other things in place as well. They may not have a legal guardian. They may have durable power of attorney. There's all sorts of different things. We know that there's been some, in more recent decades, some different kind of looks and swings when we look at what might be most appropriate in terms of those aspects, whether it be guardianship or something else. I do have just as reference information here, just some information, when we think about power of attorney, private contract between a principal and a designated third party to mutually agree in advance on procedures concerning what, when, and how the matters of the principal will be handled by the third party. I have this here. Likely, some of you are pretty familiar with things like power of attorney, but it becomes really important when we start to think about end of life, advanced care planning, those aspects and dimensions. For when we're thinking about personal representative, this is a term that's oftentimes used maybe in other ways. So we think about an independent personal representative or a legal representative. So this can be a person that handles somebody's legal affairs under another written contract. With a trustee, very different. This is a person who has the legal title to property and holds it in a trust for the benefit of another. And so we start to think about a trustee, we look at kind of that fiduciary duty to the beneficiary. So these are just 5 different legal instruments that are of relevance to advanced care planning. And I just have this here as like kind of just a precursor thought and some precursor terminology as we get into some of this advanced care planning piece. And I have just this delineated here just as a resource and a reference for you, because sometimes there's just a lot of terminology as it pertains to what might be relevant with this topic. And then in addition, I have other aspects as it would pertain to legal instruments to consider when protecting property or personal affairs. So I've done some work in this space with a dear colleague and friend, Professor Anne-Marie Kelly. She is a trained attorney, and so we've looked at some of these nuances and have published in some other places as it pertains to these different kind of things we might need to think about. So the other thing to keep in mind with wherever somebody sits in terms of guardianship or, durable power of attorney, or, if we're looking more at that kind of self-determination piece, there are considerations to keep in mind when we look at ethics, when we look at kind of this legal shift away from traditional substitute and surrogate decision-making processes, where we're now kind of looking at more of this emphasis on the principles of the individual autonomy and self-determination. So just a few kind of tidbits here. We know that guardians should only be used when absolutely necessary, and this might come into play. I always like to think about it as some of you might be familiar with Goldilocks and the Three Bears, right? We don't want the porridge to be too hot. We don't want it to be too cold. We want it to be just right. And certainly with whatever we're doing in kind of that legal space, as it might pertain to guardianship or other agreements and legal kind of jurisdiction over, or even certainly our mental health services, our behavioral supports, we want it to be kind of that just right in that Goldilocks and the Three Bears piece. All right, so I have just some information here for you, and these will be in the slides. And then certainly some things to think about as we start to think about kind of that legal decision. But I want to get into advanced care planning now that I've kind of gone through some of those things. We have some terminology that's relevant, and I have this here just in case this might not be a place you sit in, just for you to have for this terminology. But in terms of the heart of what we're talking about advanced care planning. So let's talk about some of these dimensions that might be certainly of relevance. Person-centered planning, I'll refer to it as PCP. We know that many of the consumers that we are working with, I would guess, just knowing a little bit about kind of the spaces you're working in, are likely oftentimes from a state perspective, they're really required to do yearly updates to person-centered planning. Okay, now what some of my colleagues and I did is we did a large national policy analysis looking by state across the United States what person-centered plans actually reflected the advanced care planning, or ACP dimensions. So what we did is we kind of delineated and defined and kind of parsed out, well, what are these advanced care planning dimensions? And what potentially could or should be included in person-centered planning documents. So let me just first start off with the advanced care planning dimension. So we're looking for things like diagnosis and prognosis, support needs, living arrangements, retirement, finances, burial funds, funeral arrangements, decision-making, guardianship, and advanced directives. Okay, and we took these dimensions and we looked at every single state relevant PCP document or guidance document that we could get our hands on across the United States. And it was very, very interesting. I'm going to skip these poll questions just for purposes of time, but I'm going to go through kind of these answers. So a recent analysis found that approximately what percentage of state person-centered plans accounted for the consideration of advanced directives? We're finding about 25% of state PCP's documents actually looked at the presence of advanced care directives, or advanced directives, I should say, that express the person or the surrogate's wishes. So 1 in 4. Okay. And I'm going to do just a couple more. I'm not going to make anyone put anybody on the spot here. But the other question, and I have the answer here. So the same content analysis found that approximately what percentage of state person-centered plans accounted for the consideration of identifying a person's diagnosis and prognosis for the purposes of planning. And we found it was just over half. Okay, so approximately 51% of state PCPs sought information to identify a person's diagnosis and prognosis. And just to note, we did include District of Columbia in here as kind of its separate entity, you know, and so on. So hence why we're getting a 51%. All right. So what we do know is that advanced care planning for individuals with IDD has lagged behind the general population. So if we were to poll general population's prevalence for having advanced care planning, we're going to find kind of all sorts of different things. That certain populations, I'm going to give an example, individuals with cancer are likely and should, for obvious reasons, have advanced care planning set in place. But when we look kind of at the whole, the US is not doing great when we look at kind of individuals who have advanced care planning, but the populations with IDD are lagging even beyond the general population. And so we can read about this more in different kind of places.
This is a good spot for me to direct you to
Yes.
a comment in the chat where Ann Hart is asking if you remember any of the specific requirements of these plans in Texas. And she shares a bit about when she went through this process with her son.
Yes. Thank you, because I'm not always able to follow the chat and talk at the same time. So thank you so much. And what I can do for you is I can pull it, and I have, I think we have 3 publications on this topic specifically. I can kind of pull. We did not name or call out specific states because we really wanted to be really grateful of people actually sharing these documents with us. It was a really hard lift to actually get the documents, but I can go in and kind of tease out what we found state by state. It's been a couple years since I was like immersed in this data. It was a lot of documents, let me tell you. And my eyes were starting to close from time to time because it's a pretty dry read, let me tell you, especially when we start to get into the regulatory documents, because there's the like actual documents that serve as kind of the template of what individuals who are doing person-centered planning do. But when we get into the regulatory, let me tell you, it's a dry read. Some of, you know, I always say some of this stuff is really great if you need some help falling asleep. So what I can do for you, Anne, is I can kind of tease out what that looked like in Texas specifically, because it's really, really, really interesting. Right? We're not only lagging, but then our person-centered plans are oftentimes not accounting for a lot of things. And there's great variance across the country. But what we do know is it's not happening to these large extents. So that's a really, really great question, and I can pull that for you. I'm going to kind of pivot here, and then I'm going to bring back advanced care planning to person-centered planning and talk about really why might this be a really great organic fit for our person-centered plans to really go through kind of these granular aspects and dimensions of advanced care planning. So just to set the stage here, some of the leading causes of death for individuals with IDD are now similar to the general population. We know from a longevity standpoint, things have, in many ways, really advanced. Our medical things are better. We can still get better. Don't get me wrong, but there's been a lot of advancements in terms of technology and medicine, and so things that might have formerly resulted in death in kind of what would I say a premature standpoint compared to the general population, i.e., things like respiratory disease, heart and circulatory disorders, cancer. These have shifted a little bit and have come to kind of a different place when we look at longevity for populations with IDD. So the life expectancy of people with IDD, especially in these more recent years, has shifted and has changed. And now these life expectancy, when we look at average lifespan, these ranges have gone into early 50s to 60s. And certainly there is variability as we look at um, differences in conditions coupled with whatever co-occurring conditions may or may not be present. For our older populations with disabilities, lifelong juvenile onset conditions, I should say, what's happening is that they seem to remain at greater risk for certain things. So when we look at premature and avoidable death compared to the general population. So we are seeing that the numbers are shifting and certainly advanced age trajectories and probabilities are rapidly increasing, but we are still seeing other things going into play because of co-occurring conditions. So I have a few here, and we have some physicians and dentists here and all sorts of things. So this is probably nothing new to many of you, but we do know there are some common medical conditions experienced among those who are aging with IDD. Why is this important in the context of advanced care planning? Well, these are things to think about, right? These are things that might come into play. I do have pain on here twice as something I inadvertently did, but I do want to just give a nod to pain here. When we think about chronic pain, we can think about it kind of across the lifespan. In our children and adolescents, general population, we're looking somewhere at like 30%. And as we kind of kick the can across the lifespan, we are seeing things like high impact chronic pain and other things come into play. For populations with intellectual and developmental disabilities, for me, one of the reasons I'm really interested in things like chronic pain, subacute, acute, chronic pain, whatever, high impact chronic pain, is because these populations oftentimes have very different experiences with pain. There can be some hypo or hypersensitivities, blah, 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 right? We can think about this, but what we do know is we don't always have this great metric to assess pain in many populations. Okay. And the longer these trajectories of experiences with chronic pain go on, the worse they can be. And so when we take general numbers, people who are experiencing chronic pain in the general population, 80% of them are deemed and believed to have things like depression, which is much higher than the general population. And I bring this into play because as we think about perhaps as people are aging normatively and perhaps with some non-normative co-occurring conditions, chronic pain might come into play as well. And so while me putting pain on here twice on this slide was certainly just an oversight, oftentimes I look at that and go, oh, but it's so important. And so, in the context of that, I bring it back to really the importance of some of these conversations around advanced care planning and certainly updating any ACP documents that are in place because we know things like dental pathology, sensory deficits, obesity, pain, osteoporosis, and increased fracture risk are at play. So I'm just going to share a little bit from something that my colleague and another piece that Dr. Jackie McGinley and I published. We were looking at a comparative case study of hospice and hospice end of life for aging adults with DD. And here's just a piece that I want to read. Quote, although individuals with developmental disability are living longer, there are subsets of the population who are at increased likelihood for chronic, life-limiting diseases and conditions that can result in shorter life expectancies. Providers should consider early palliative care involvement for those with serious illness, diagnoses, and who are amenable to supportive care in addition to their regular medical services. In addition, this comparative study, both of these patients received late hospice care within days or weeks of their death. And I want to note there, and I'm going to stop my quote there, that oftentimes, and I did some work looking at even kind of the numbers with hospice of Michigan. Many years ago, we were looking at kind of numbers in that last year of life. People oftentimes, and this stands as a whole across the country, not just relevant to Michigan, but they're often not, even with the general population, accessing hospice and palliative care at perhaps those more ideal times. And so what's happening is we're doing a lot of life-saving initiatives, talking about general population, for oftentimes too long, and that quality of life, quality of care, the ability for some of these medical pieces to actually be efficacious are not there. And so I've had a lot of conversations about this, and I did actually do some research for Hospice of Michigan at one point, looking at what this looks like. And we know this is really oftentimes the case across the country. And so the same holds true, perhaps in a different light, but for our populations with IDD, when we're thinking about these common medical conditions, that's important to think about. But what we do know is there's a decreased likelihood for people to actually access these services at the right time and the right place. All right, I have some, if you're working with the Down syndrome population, I have something for here from NDSS, the National Down Syndrome Summit. They're phenomenal. I have this just here as a resource for you as we think about some of those common medical conditions and how this might play into some of the conversations and the dialogue that might be relevant and germane to advanced care planning. Other things to think about when we look at those who are aging with IDD, they may be associated with other realities that are really important to think about. So these unique factors disproportionately shape the experiences of this population at end of life, but also what this looks like for their caregivers, paid and unpaid, for their family members. So we think about those behavioral health needs. When we think about complex co-occurring conditions, comorbidities, when we think about things like polypharmacy, all of these come into play. The other thing to think about when we're looking at kind of this advanced care planning task, if you will, venture, whatever we want to call it, when individual has so many providers, how do we bring these people into play? All right, so just some things to set the stage. And we think about life expectancy, right? Living with complex medical challenges for longer than the general population is something that we are oftentimes seeing for populations with IDD. There is an underutilization of hospice and palliative care services. I have that bullet here really, really intentionally, and I've mentioned this kind of through and through because this is a really important piece to think about when we look at advanced care planning. How might we use advanced care planning in the context of person-centered planning as a mechanism to actually have optimal utilization or more optimal utilization of things like hospice and palliative care services? And the other reality we know for individuals with IDD is that they have higher rates of hospital and institutional deaths. And that's another reason why my brain continues to go back to is these are all reasons that really align in favor with how do we move forward this advanced care planning piece, and how do we help individuals with IDD and their families in that process, because that is a process. All right. So certainly these argue for really kind of pushing the needle forward in investing the time in the time and the energy for advanced care planning. So other things to keep in mind is we know older adults with IDD are a growing population. I've talked about this a couple times. We do know that advanced care planning is a recommended best practice for adults with IDD, certainly for the general population. If you're thinking about your own life, I'm not discounting our general population here, but in the context of IDD, we need this. And we do know that Medicaid requires recipients with IDD to have person-centered plans. And so as we look at this, how might we utilize those person-centered plans as a framework and a mechanism to move forward these dimensions. And Cameron, I see you unmuted
Yes.
yourself, so thanks for chiming in.
I'm leaning forward because I want to bring to the fore some really interesting points that both Kathy and Beth have put in the chat, namely that in addition to knowing the logistics of putting these plans in action, the caregiver's emotions of perhaps admitting I am no longer capable of caring for the full needs of my loved one, and it's time to move on to some legal documents.
Yeah.
Can you speak to some of those concerns?
Yeah, no, it's a huge thing. And the other thing that we found, so I published a piece with also a good friend. I guess I only publish with friends, Cameron here, but Dr. Jillian Graves, and we looked at just future planning in general. Not even specifically advanced care planning, but for future planning, what we're finding is, at least based on that national study, is that those family caregivers, and we would consider them in that study to be aging parental family caregivers of adults with autism specifically. Some had intellectual disabilities, some did not. But there were a number of different barriers for them to even engage in planning, right? From a time perspective, the emotional standpoints, what this meant, that they didn't feel like they could even start to think about some of these aspects. And really, how do we start to think about that of what services might be put into place to actually begin to normalize this? I'm a mom of, and Catherine and Seth have heard all, Kathy and Lucy have probably heard all about this, but I'm a mom of, I have 3 young girls. And I think about just even this work of, how would you even possibly do that in real life, in real time? I have normatively developing children, and they are wild, and they're probably climbing the walls of my house right now. But you think about what this looks like for populations who are navigating so much, and maybe, especially in those invisible caregiving populations, not having those dialogue exchanges where we can start to normalize this of, hey, this is really hard, or hey, I'm aging simultaneously.
I want to pose the question that Kelly Martin has in the chat. She says, can you help distinguish between palliative and hospice care?
Yes. And what I'm going to do, I'm going to put it in the chat. How I think about it is I think of palliative care as comfort care. I think of it as comfort care. With hospice, and what I've seen, um, is that like you can have in-home hospice or in an institution hospice. So I visited people who might be in well, I visited both, but I visited people who are receiving in-home hospice care. They're in their final days, whatever final days means, because we do know that there are live discharges from hospice, but they're receiving support. And when we start to think about not being offered things that would prolong their life. And there's other things that come into play. So what I'll do at the end of this, I'm going to put some resources in the chat so you'll have an actual really, really good terminology for this and definition for this that won't be kind of paraphrased. But with hospice, I oftentimes think about it as in an institution or in a home, and we're doing things kind of in those final days. Final days might mean months. Oftentimes, what I do know about hospice is that people are accessing hospice care 48 to 72 hours in general. And so what we know again is that people can't access that as much. I worked with a woman who was in hospice. She was in there for months. And there were certain protocols put in place. And this is oftentimes what happens, where the family receives some education. Those who might be going in receive some respite care. The nursing staff with hospice, they're kind of all on board. One of the things that does become a big issue, and this is a really good question, I just want to make a nod to this, is that there is a lot of educational needs. In hospice, certain medications may or may not be given. Certain things are happening. One of the big things that comes up, especially when we start to think about families in general, and then if we get into cultural, religious beliefs and so forth, this can come into play as well as when they stop doing hydration and food intake, because families will sometimes think, oh my gosh, this is against my religious beliefs. I'm not right. I'm not feeding my loved one. We do know that with hydration, for example, we can actually pose more discomfort. And certainly with nutritional intake, we can pose more discomfort, and we can actually exacerbate risks of aspirations with some of these things. What the body is doing, like when we think about hospice, is it's shutting itself down. I see Lucy, if you ever have anything, I see you, I see your face now. So if anybody has something that they want to add, but what I'll do, just so that there's no, there's kind of this clear indication, I'll put some resources in there just to peruse, because there's so many complexities, and the work I've done kind of in that space, just even seeing this. I have a colleague who's now at another university, but she solely studies live discharge from hospice, because there are times, and I'm not trying to dangle this glimmer of hope, but there are times when that's a case too, for people that this has been really the crux of her entire research career. So really great question, but I'm going to give some really solid definitions in just a little bit here. The other thing I want to mention is social support. In the work that I do and the work that I publish in, I talk about two types of social support. I talk about formal, so these are paid supports. They might be government paid, they might be out of pocket paid, they might be paid through healthcare dollars, Blue Cross Blue Shield, whatever somebody might have. And our informal social supports, these are our unpaid networks, family, friends, and neighbors. And this can be really important as we start to think about, how do we walk along someone in their caregiving journey or their aging journey, whether this be the caregiver or our patient, consumer, loved one, right? However we want to term that, because this can play a huge role. And so I go back to the really, really great comments that have been made in the chat that Cameron articulated, that some of you have made, of how do we help families when it's too much to even get around, that somebody might not be able to, maybe no longer able to engage in the type of care and the level of care that somebody needs. So that comes into play. And the other thing I just want to kind of make a mention to, as I'm thinking about this, maintaining social support network, that's key. And I do see a role for professionals in supporting this, right? There are ways to do things in an organic way that can help support and facilitate without even maybe being the direct person to give that social support. That there's things that we've done here in Michigan and so forth in kind of the disability world in general. But the other thing to think about is many of our family caregivers are aging. And as they age, they also experience their own health declines, but they may find that they are caring for somebody who has a lifelong disability, i.e., as IDD, and they're now caring for a spouse. They're now caring for another loved one. And so I have some research where I've talked about compound caregiving, because this became a really large piece of interest, as not only do the care needs change, the caregiver's abilities might change, and now they're simultaneously a compound caregiver. So I see Kathy here. Kathy, please feel free to chime in at any point here.
Chrissy, when you're done, I didn't want to interfere. I just
Oh,
wanted
no,
you to
this
know I
is
wanted
great.
to answer. Okay.
Thank you.
Well, I think as always, Chrissy, excellent discussion, excellent research, and important points that need to be made. And I love all of the people on the spokes who have added information specific to Texas. It's just excellent, the information. Beth, your comment was really an important comment to make about kind of the exhaustion and also the feeling of shame. And it happens in the general population when people have a family member with dementia, or some type of dementia later in life, and people feel shame when they have to ask for help. But in the IDD field, it's across the lifespan. They have that kind of caregiving responsibility. I think, though, all of us working together to try to take away the stigma of asking for help, making sure, if we know people who have never had a diagnosis, families, because families were hesitant to get involved with the service system. I think it's important for us to encourage them to do that. And it's important for all of us to teach others there's no stigma. In the general population are supporting people with IDD. And the very last point that I want to make is that I think all of this information is useful to help give families tips of how they can do preventive activities over a lifetime. I think it's essential. That helps take away a feeling of shame when you have this information and then you're able to apply it. I think too often we keep talking about the need to develop training for families without recognizing the pure exhaustion and lack of time for many families. And so I think our role needs to be to train organizations who support families to have this information and be able to give it to them, have training available if they want it, and smaller, they can attend the larger training. Most families I know are too exhausted. I mean, imagine if someone were telling you, Chrissy, to learn anything that you need to know about working with your 3 young children, you got to attend a 2-day training and then maybe you'll have enough
I mean, even a
information.
book. I'm like, what? What are you talking about? I'm
Yeah,
not going to read that book. How would I read that
yeah,
book?
I
Yeah,
know.
no, I
And I
mean, you
think
make
we
so
don't
many good
recognize
points.
that. So thank you for everything. Go ahead.
And out, Lucy, I see you too, so feel free to chime in.
Yeah, so I just want to thank you. Thank you both. I want to just build on some of the things that Kathy was saying. One of the things I've noticed is people have a very big misunderstanding of the nature of hospice services. And part of the emotional reaction is the belief that if you ask for hospice services, it must be because your relative is at death's door, which is not the case. Different hospice providers will vary in terms of how they will or will not support or intervene. So I think it's a very important thing, and I like that idea of educating providers for our population in terms of knowing what are the services, how to access it, and also maybe important to develop agreements not only with hospice providers, but local hospitals, with nursing, skilled nursing facilities in the area, because there are people who have to move in and out of skilled nursing for brief periods of time because of one or another exacerbation of a medical condition towards the end of their lives. And so, very often, there's a desire on the family or support agency's part to access services, but they encounter barriers on the provider side,
Yeah.
uh, in terms of, well, we don't provide those. Your disabilities agency in your state is responsible for everything that pertains to this individual. So there's education needed on both sides in terms of
Absolutely. And even with that palliative care, this can go along with curative support. So somebody could be at a stage of some form of a serious illness, but they can be still receiving curative support, curative treatment in palliative care. So that stigma of, oh, I'm going to put my loved one in hospice and that's the end of the road, versus maybe we even start with some of this palliative care before, and maybe it gets to a point where hospice care is needed or it's well received. And some of those psychological barriers that I feel like you're talking about, some of these, how do we navigate this landscape? But then how do we even help with some of those psychological barriers of, right? Is maybe somebody comfortable receiving palliative care? And how do we do this maybe earlier? And then we know with, hospice care, it's oftentimes they say, right, that somebody's going to be in there with no longer than that kind of 6 month, even though we know it's not always that, and it's usually quite less, but not always. So I
yeah,
see some other comments, and then after those, I can get kind of the last just pieces of my slide at any point too. But please, anybody, Seth or whoever's next.
Kirsty, can I just add a comment? Yeah, so I'm a neurologist, that those that don't know me, so I'm going to be giving you a medical perspective. So I treat many chronic diseases, ailments in older people, dementia certainly, but I look at issues of palliative care, and this is kind of what everyone's really saying, is discomfort. So I have a lot of medical conditions that I treat: Alzheimer's, Parkinson's, multiple sclerosis, stroke, And these are individuals that have acquired a disability, whether they already had a lifelong disability or not, is they acquired a disability on top of it that is leading to some level of impairment or discomfort. And it's really affecting their quality of life and their ability to get satisfaction or happiness out of their life. And that's where I look at palliative care as that kind of service. I don't even think of it at all in terms of, their age specifically or whether they will ultimately be on end of life care, but it's really there for comfort. And often the problem is they may not be able to achieve those types of comfort services or services easily from outside entities coming in. So a palliative care will often have like a nurse practitioner that will come to their home and they navigate the kind of care they can get, both OT and PT and speech, and they navigate those kinds of things to enable them, but they have an outcome. They have to have an outcome of what it is they're trying to achieve for them. Otherwise, they're not a candidate for palliative care. End of life care, which is hospice care, is really the last year of your life, of the person's last year. So as you're saying, it's not immediacy at all, even though it can happen in people that something happens, they're going to die soon. It's the last year. And the tricky part of the last year is how does anyone predict when you're going to die in a year from now? When you start putting the calendars, okay, ready, start clicking 30, 65 days. This is the rest of your life. And so it's not to be funny about it, but that's really what it is. And then when you're telling people, it really goes down to the conversation that you have a terminal illness. And that's really what it is on these conditions. And that's really where it has to come down to that type of conversation you're having with them of a reality. Because in most cases, I would say in these conditions that we treat that are end of life care, whether it's cancer, they have a horrible stroke, they're going to die, Alzheimer's disease, is that I'd say most healthcare practitioners do know that this person is going to be dying in the next year or so. And it's all a matter of coming up with that and telling them that and dealing with how you feel personally. It's really about you having an issue with it and not be able to say it. They might wish you would be honest with them. They would probably be happy if you can just be honest with them and don't, paint this rosy picture that may not be. Really be honest with them, but do it in a very sincere, sweet, understanding way that even though they might be in palliative or then end of life care, hospice care, that they're not dead yet.
Yeah.
And therefore, what they can do from now till then is still try to do the best they can. And really, you're doing it at the nicety and sensitivity of their lives that we all want to die peacefully in comfort without pain and all that.
Yeah, no, those are such great points of like, all of these things and who might have kind of the stigma or the challenges with it and how do we go forward. I do have, thanks, Seth. I appreciate it. I do have some information as it pertains to these low rates of ACP that do exist. The other thing I just want to kind of make mention to is that we know that Medicare requires people with IDD to have person-centered planning. ACP is not required. It is not a necessary component. However, as we looked and took a deep dive into hundreds, it was really a great read. Hundreds of documents, state-specific documents, were like, this would only make sense. And some states are talking about these ACP dimensions. So I'm just going to kind of scoot on forward here. I have some barriers. I want to be kind of conscientious to your time, but give you some kind of on a high level, some relevant pieces. We have low rates of ACP. This is documented in a lot of empirical studies. I have one here from Dr. Chung and colleagues. It was published in 2020, but looking at these specific barriers. So this is a quote from their piece, but limited patients' participation in autonomous decision-making, cognitive and emotional barriers, which have been discussed, especially we've talked about these emotional barriers, but certainly cognitive barriers are a piece as well. Lack of readiness and awareness of early discussion, and then an unprepared healthcare professionals and healthcare system. The other thing to think about that I think is actually really interesting is thinking about decisional capacity. I think that's really, really relevant as we think about, what does this look like in terms of one's ability to make their own medical decisions. And when that's not the case, especially with the ID population, who's coming into play? How are we engaging those partners, those care providers, and who are those partners, support caregivers and things like this to bring into this? We oftentimes have similar questions of capacity arise in different context, when we think about even in court of law or the ability to make decisions about personal care and finances. And so sometimes we might have some takeaways from that. We do want to make sure that we're avoiding confusing information, jargon. We make things easily accessible to both our caregivers and certainly our individuals that we're supporting who have ID. But certainly all those on kind of that team who might be looking at it. We also want to I also want to mention kind of this difference in meaning. And so there's different ways information can be approached and to be accessible so that people have kind of the meaning and the essence of what somebody is talking about and really eliminate those opportunities for confusion. So I mentioned earlier, based on, and I don't know if it was Kathy or Lucy, it might have been somebody, but it really kind of jogged my memory, or maybe a comment from the chat of the stigma. I think it was Kathy who talked about kind of that stigma, the shame, um, the exhaustion, right? We know this is the case, and I had mentioned this piece I published with Dr. Jillian Graves, but we look at a lot of things just in the future planning world, not even specifically advanced care planning, that families are prolonging planning for a number of reasons. So finding it very difficult to identify care supports in the future. Okay, so again, just general barriers to making plans or decisions. Oftentimes, it's a time piece, fear of the unknown. So those emotions are bringing, really oftentimes coming into play. And then feeling the need to make plans and decisions now, but not acting on it. And this was something that a lot of the families in one of the national studies that I conducted, and I interviewed families across the country, but it was very, very interesting because I never asked about this. I never asked about this. This was a theme that emerged. So it was a mixed method study. I did a online survey, and then I followed up with interviews with anyone that might be interested. And I ended up interviewing probably a lot of people, maybe too many. It was a pretty robust response, and I was very curious, just given kind of the array of disability. So I interviewed anyone that was interested, really. And so I looked at about 51 people specifically. But this fourth piece here, feeling the need to make plans and decisions, but not acting on it. And so it was always hanging over people's head. So again, I never asked about this, but people talked about it organically. It just came up. And so what that means to me is like, how do we provide a realistic entry path and having these conversations and walking along somebody in this journey, because it's something that caused, I would say, distress for many, many people. So I have some things just about who's most likely to have advanced care planning. And certainly the pandemic really unveiled a lot of things. It really unveiled things. And when we think about some of the really kind of horrific things of people with developmental disabilities, or any person in general, but certainly when we start to think about somebody who might have some cognitive, communicative limitations, right? They're in these hospitals many times alone, sometimes at the earlier parts of COVID, even without a support person, and how scary that was. And so as we start to think about the pandemic and maybe some lessons learned in that visibility of that reminder for what we can do with advanced care planning and future planning, even future planning in general. All right, so I have a lot of things. I really believe now is the time. I think there are opportunities to loop in siblings. We do know from our national task group that we do know that there are a lot of siblings, and this can be oftentimes really, really important in general. I'm going to fast forward here. I have benefits of advanced care planning. These are talked about through and through. If we look at different empirical evidence, if we look even at large medical facilities, University of Michigan talks a lot about these, but we do know at a high level, there are a lot of benefits. So advanced care planning, people can have better informed care during those hard times of change, times of crisis, times of transition. We can promote better patient-centered care. People can oftentimes have better end-of-life experiences where they're not, again, I go back to that reality is that many individuals with intellectual disabilities are dying in institutional settings. This is probably not the preference. And so if we can have better end-of-life experiences through good planning, right? Good things. Reduces decisional burdens. So for families, for loved ones, For the medical team, this is helpful, improving quality of life, so decreasing use of aggressive treatments, unwanted hospitalizations, and so on. And then certainly increasing the likelihood that providers and families understand and follow medical preferences. This is huge. So I have some resources on there as well. There's a link at the bottom. I have some decision-making challenges. I'm just going to briefly talk about this. The first one here, awareness of dying wishes that were documented where families were prepared, but validation and support needed in the moment. Maybe that was there. The second piece, awareness of dying wishes undocumented. So because there were undocumented wishes, in this case, EMS had to initiate treatment and medical control guidance was needed. The third, unaware of dying and wishes were documented, families were in shock. Right? They were in shock. And so there was the expectation that medical personnel could stop the dying. And the fourth one, where somebody's unaware of dying wishes and it's undocumented, this was the worst case scenario, in my opinion. Families were unprepared, uncertain, and frantic. And so this is from Dr. Waldrop's work and some of her colleagues who does a lot in kind of the end of life space. So in a nutshell, we can improve end-of-life care by integrating ACP into conversations and routine planning processes. So I would argue very strongly for person-centered plans, but done right, done effectively, and done intentionally. I have some just food for thought pieces here of what this could look like. And a quote here, when completed across the life course as a collaborative process, ACP has been found to contribute to end-of-life experiences that reflect the values and priorities of the individual with IDD. Okay, and I have some resources. I know that I'm over my time here, so I'm going to be mindful of that. But I just want to make a couple notes. One, this is a moving target. Our caregivers their needs are changing. Services are changing far too often. We know that there's a provider professional bandwidth issue. This continues, and this continues probably at more elevated rates. And so we're going to follow that moving target. We're going to update if we can. I say we, just as a country, whoever wants to do that, right? But we're going to update as needed and recognizing this moving target and this need to continually revisit and discuss. This will not feel like such a laborious task, likely, if that just kind of like organic revisiting is done with perhaps professionals who are maybe guiding that process and taking that heavy lift off. I have some information just in terms of considerations. We want to certainly consider it the multiple caregivers, the multiple prescribers, those different kind of co-occurring conditions, age typical and age non-normative or non-typical and so forth. I have some resources here. This is from the Ontario Medical Association. I thought it was great, but just some things that might be good handouts and things to think about. And hold on. We're going to get there. I have just kind of a little guidance thing here of how do we plan for planning. This has been helpful with many of the families that I've talked about in any time of transition. And I'm just going to leave with this. And there are resources in the back. So an hour of planning can save you 10 hours of doing. I think this just is great, but it can really ease some of the emotionality, ease some of the confusion, ease that decisional burden. I am the biggest proponent of ACP and when possible done in kind of that context of person-centered planning. So I'm going to just stop talking here. I am Seth, and I'm going to pass it over to Seth for any questions, comments, insights.
Yeah, Chrissy, thank you so much. I actually had to take another quick call. I feel bad. I might have missed something that you said. I just want to make I guess a philosophical comment, or at least a comment of what I see in the aging populations. And it's really it's something I don't want to come off too cold in how my comment's going to be taken here, is medical utilization of the last few years of life in our seniors. And I'm sure this will come as no surprise to anyone on the call that has been supporting their grandmom, their parents, their friends, themselves, I guess, who are in the last years of life. And when you're medically fragile, which is often what happens with people, medical utilization of services. And that a lot of it is really more of acute medical service, in particular ER usage, hospital usage. And as a physician that treats people not only in a private practice setting in my office, but I also do hospital care. So I'm often asked to see, as a neurologist, people that are 70, 80, 90, 150 years old that basically have, older chronic problems, and they're in and out of the hospitalization. And yet the difficulties is that they're in their last year or life or so, whether or not they're already been DNR or taken all DNR, whether or not they've have, the reality of what their life is. And it really has to, I think a lot of it has to do is what is being told to the families, whether they themselves or the patient themselves, about the reality and the choices that they had to make. Because what I often find, again, I want to be very careful how I'm coming across in my comment, is they come in and basically doing things to people when I feel that it's almost torturing them. It's almost doing blood tests on them and imaging in them and doing and putting them in a cold, bad environment in the hospital, which no one wants to be in. Believe me, I worked there. I don't want to be there, and I worked there. So I think there has to be some sensibility of having this conversation, whether that's advanced care planning or something from a behavioral psychological standpoint, to really help with what is it that we should or should not be doing. I know it's not black and white, of older people at one point of their lives, to help them, their family, and our society and our system. I'm on my soapbox. I say it on my
No,
soapbox.
I think it's so true and it's so important. And as we continue to see more and more people with this, in these different states, I mean, I think it's just so important. And you're right. Like, you're in these hospital settings and you talk about them as, cold, and you don't really want, right? People don't really
Yeah, I
want to
mean,
be
I
there.
often will discontinue. I mean, they come in. I'm a stroke doctor. They'll come in, 99-year-old person, they're already advanced dementia, and they're ordering every test in the world. And it's like, what are you thinking? I mean, it's just, I
Yeah.
hate to be cold about it, but there's got to be. I'm not being mean. If anything, I'm being nice.
No, I don't think it's cold at
I'm
all.
actually
I've had
balancing it
these,
because you have to remove the guilt.
yeah.
Like, how can I not care for them? Well, you're caring for the person by caring for them as emotionally caring for them.
No, I've had these. I have a friend who is at Johns Hopkins. She's a palliative care social worker, and she's working with cancer patients. And she's like, Chrissy, at some point they've grieved it, right? They're sick, they're
Right,
ready, right? They're ready to kind of transition, and they don't need continued, chemo and radiation and this and that and poked and prodded. But I think it's like that. At like what point do we start to look, yeah, hey, you're 99, you give this example of, hey, you're 99 and you just had a stroke, and we're going to order every single test. And is that really what somebody wants? And do they even know in those moments that that's really, when you're not feeling well, it's hard to even
right. But
start to
I see that
process
Beth, you
these
wrote a
things.
comment, because the other part is that if you have someone in the state system, so if I have someone with and I've seen this in particular, someone with Down syndrome with advanced Alzheimer's disease, is that they're under state guardianship in New Jersey. And basically, no one would step up and say, let this person die.
Yeah.
They put the feeding tube in this
Yeah.
person. They're and it's almost like they kept going to the hospital. I mean, I said, who's speaking for this person? Who is actually stepping up and really speaking for this person and treat them humanely and not keep doing them and let them die? Let this person die.
Right.
I mean,
Right.
I just think it's terrible we sometimes do to people.
We've prolonged the dying process. We've prolonged
We
it.
think we're protecting them. And in the state
Yeah.
system, we're protecting them. We're here to protect them against these other mean, bad people. Therefore, we'll keep them going forever. And it's like, come on, there's got to be a system of care. And there is. And it's the system is often horrible and difficult. You need to kind of get like two different doctors, and they got to agree, and blah, 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 blah.
Yeah, and
And it's just,
that's the thing. The doctors have to agree. And I've talked
yeah,
to, my training's in social work, and I've talked to many social workers, and and we're yelling at the doctors, and I'm like, oh, this is really bad. Like, every right, and it becomes this huge decisional burden. But that's why with this advanced care planning, these conversations can be done, and then it's like,
right,
here's the plan. I even look at like,
right,
I do some work in, grief and loss, and I've watched as somebody dies very unexpectedly, and what happens, right? Everybody has these stories. They've heard their neighbor, their own families, and what happens is the family like unravels because there is decisional burden or disagreements, that it's really nice when somebody says, here's the plan. Here's what somebody gets when, when somebody's sick,
They
and
could
this
always
is what we
change the
want.
plan. I mean, even if the plan is set, you could always alter and change the plan too. I
Yeah.
appreciate this conversation. It's really rich. Thank you so much.
No, thanks, Seth, and thanks for the work you do. Kathy.
Yeah, I think something important to be added and think about is, I think you may have seen my comment in the chat box, is that I've worked with families who have done all the advanced care planning or think that they have. And then when end of life comes and the end of life is within hours or the day, they suddenly find out a new regulation, a new form that has been added, and they have to find somebody who can sign. I mean, I've gotten calls when I'm traveling from families saying, can you sign this form? And I can't. And luckily I've been able to find someone for them quickly who could do it. But I think the plan needs to be continually revisited, and they probably should have someone legally. Again, this is something in organizations. There could be people trained to do this who can update caregivers when new regulations come in and there are new forms that are mandated.
No, that's great. Thanks, Kathy. And I'm not able to read as quickly as all these good chats are coming, so I didn't see that one. But no, I think you're so right. Continuing to look at what are the regulations, making sure people are really charged with doing this. I've given similar talks in different kind of to different audiences, and people ask really specifics on guardians. And I was like, guardianship. And I'm like, well, it's state by state, but I don't have training as an attorney. So really looping somebody who's well trained with the right legal background that's really backing that up so that that is appropriate and so forth. Yeah, no, thanks.
Chrissy, of
That's
all
hard.
the wonderful comments, I'll tell you that it was wonderful while you and Dr. Keller were verbally conversing. There was a vibrant chat conversation as well, echoing many of the same sentiments. In that, there was one question I wanted to pose to you from Ann Hart. She says, do you have a sense that hospice organizations are educating themselves about IDD?
Actually, that's a really good question. I don't sit in that space predominantly. The last specific hospice work I did, I was looking at kind of that last year of life in terms of financial expenditures, which is profound, let me just say. Seth Keller probably knows this, and some of our other MDs certainly, and maybe others. That's a really great question. I get the sense that as a whole, and certainly this is a subset right here, people are very well versed in this, but the medical community as a whole across the country is not. One of the things that I'm really a big fan of is PACE programs. These are like kind of these all-inclusive programming. And I know I've talked with Seth and a colleague and friend at University of Michigan Medicine about, could we actually find a way to utilize PACE programming for IDD, right? Very, very, very specialized programming, because I get the sense that whether it be hospice, whether it be any service in aging, is that people are not typically well versed. That's just my general sense. I do see that every now and then there's like pockets, right? There's pockets of somebody doing something really, really awesome. Even Alzheimer's Association here in Michigan, there was a person a few years ago who was solely looking at ID and dementia at the Alzheimer's Association. And I haven't since found it in any other state, but as a whole, I don't know. Maybe Lucy, I see your hand up, but I don't get that sense of that there's anything really robust being done.
Yeah, I agree with you. It's not robust. And I'll talk from a California perspective. I think it has to do with the demand for hospice services for our population. So as we promote having people utilize these services and palliative care, it is more likely that agencies that provide this care are going to be interested in getting more educated about their potential service recipients. And I do know several communities in California where there has been an agreement or an arrangement with local hospice providers through hospitals or et cetera, in which there is kind of a mutual education as well as some kind of agreement about you, but it's not, overall, it's not well utilized, not well understood. And, and I would have to say this is also true for the general population, right? I don't know how, right? So
Yeah.
more particularly for individuals with IDD.
No, and that's so hard. Like it's so hard because it's so important, but until people get the right information, until that information source is seen as something that's really important. No, that's a really great question though, is that, how do we even move forward in getting places like hospice and other relevant medical parties and communities, whoever that might be, to really have some of this information at the forefront in the context of IDD? I know there's a ton of chat. So if I missed anything that I should be seeing, Cameron, just let me know. Um, I haven't been able to follow all of them. There's so many good ones in there.
Just the most recent chat comment from Beth is inspirational, I believe. It says, one person at a time. So Chrissy, I think that helps bring our time to an end, saying thank you for sharing your expertise. I could tell by the liveliness of the verbal conversation and the chat box conversation that this was a much needed topic and very informative. So thank you for sharing your time and expertise with us. I guess I'll close us out and maybe turn it back over to Catherine Piers, who often reminds us of the date when we gather again the next month. So thanks everyone for being here.
Thank you.
Thank you. Chrissy, I'm going to ask you if you would to stop sharing your screen because I have another one that I need to put up that's going to have on it a QR code. Let me get it up here. And we would ask if you would get it going here. Just take a, where did it go? There we go. There we go. Well, that's interesting. I'm not sure why it keeps disappearing. Is it disappearing on your end too? Yes.
Take a
I have-
picture quickly before it disappears.
Yeah, everybody act really
Hurry up.
fast here.
Ready, go.
I'm going to try one more thing and see if I
Wow,
can
damn.
get it up here because it is a rather important thing. We have one favor to ask of you, which is, would you please, when I get it up here, try to, hopefully it's going to come up. I'm just going to leave it like this because for some reason when I try to move it, it goes wonky. But that QR code there is an important little piece of our project here. The Texas DD Council, Developmental Disabilities Council, who funds this project, would love your input. And so if you could, with your little smartphones that we all have, just scan that QR code and just take a minute or two to fill out the survey that they have. It'll only take you a couple of minutes, if that. And we would greatly appreciate your doing that, as would the DD Council. And our next session is going to be August 20th. And as I said earlier, we are going to have Dr. David Frey from the University of Texas Houston Health Centers. Dr. Frey is a dentist and has worked with this population for many, many, many years now in a variety of capacities, actually. And so he is going to be talking to us about dental issues, important dental issues. And I have to say, I've heard Dr. Frey speak before, and he does a wonderful presentation.
He's a great speaker. He's very
He really
entertaining.
is. Yeah, he's entertaining, and I learned a whole lot about him. I've always sort of thought of, and Cameron taught me this, oral health in June. Oral health is more than brushing your teeth. I think that was even the title of a presentation you did. But Dr. Frey has a lot of interesting things to say, and particularly about how sometimes unknown underlying medical problems can be picked up on by examining the mouth and the appearance of teeth and so forth. And sometimes that can relate to behaviors that you see in people. So it's an important conversation. We don't talk enough about oral health. So we thank Dr. Frey for being with us next month. So mark that date on your calendar. Please do the QR code. And last but not least, if you have any individuals that you are working with that you are having some challenges with and you would like our hub team to weigh in on it, as those of you who have been joining us in the past know, we frequently have a case presentation. Unfortunately, we were not able to get one prepared for today. But if you have people that you're working with and you've got some challenges with them maybe, or just something that's kind of puzzling you, please let me know. Cameron, I'm going to ask you to put my email in the chat box if you would. And shoot me an email, and we make it really easy for you. As you've seen, if you've been with us, it's not hard. I help prepare the case presentation for you, and I'll do the presentation, and you just need to be there in case we have any follow-up questions for you. So Cameron's got my email in the chat box. We would love to hear from you. And as Cameron mentioned at the top of our time together, the theory is, all teach, all learn. And so those cases are very important to us to, meet that goal. So thank you all very much. Thank you to our hub team members. Special thanks to Dr. Marcek Topolewski. That was a fabulous presentation. And I'm going to echo what Cameron said, lots of good back and forth going on in the chat box, which really shows that this is an important topic for a whole lot of people, and one we could probably talk about for the rest of the day. But some of us, all of us perhaps, have to get back to work. So with that, thank you all so much, and we will see you next month. Bye, everybody. Take care.